So yes, it's always good to be back. To October Summit is definitely something everybody look forward to. And I was listening to the some of the speakers yesterday, and we were discussing a lot about the dilemmas that the program managers have while designing programs. And I start with this conversation with this statement which Sightsavers generally puts in our website. Say we start with sight, but we don't stop there. Yesterday we were discussing about if I say that we don't stop there, then where do we stop and how far we can stage? Some people were saying yesterday that in eye care, probably we have been happy in achieving less or just plucking the low hanging fruits, and we have never thought of stretching it a bit too far. But let's see how far we can stretch and what are the feasible options for us, and how much Sightsavers India could do in our programs in India. I'll be sharing mostly from our program experiences in across 10 states in India. So before going into the details of the program, I just wanted to touch upon few of the narratives that is going on globally. First, most of you have must have heard about this universal health coverage. It speaks about three large pillars or principles. One is about population coverage, the one is disease coverage, and the other one is about the financial protection. So at Sightsavers, we try to align with these thoughts that how our programs are contributing towards the three large pillars of UHC or universal health coverage. Another report which is very important is on World Report on Vision, which also lay emphasis on empowering people and communities. And along with that, in the year World Health Assembly resolution for 2020 and also in 2021, this IPEC model, integrated people-centered eye care, which also enhances or reinforces what World Report on Vision says, that at the core of our program, the communities and people's well-being, their expectations, their aspirations has to be figured out. Finally, in 2021, for the first time, eye health as an indicator was considered as part of the SDG goals as one of the indicators. So effective cataract surgical coverage and the refractive error coverage, these are some of the indicators which are first time considered at the development goals. And all the eye care, fraternity, the global leaders, they agreed on this eye health sector strategy, which calls for three prominent strategies. One is elevate, integrate, and activate. And if you read through this sentence, it speaks much beyond eye health. It just speaks about the economic well-being. It speaks about social issues. It speaks about development issues. For the first time, it has started speaking about how eye health can contribute towards a larger developmental goal. And we at Sightsavers also try to align with these kind of global narratives and the thought process and design our programs accordingly. I'll go to my next slide. And if you have any questions, I think we'll have a question and answer session at the end of all the speakers after they speak. Then we can address some of the questions. So what are the challenges that we face when we want to do a good program and there are resource restrictions, there are a global narrative, and we as an agency, both working in India and globally, we try to align our thought process towards all these narratives and frameworks. But most of the time, challenges that we face is that there is a wide scale inequity in accessing eye health services. When I say inequity, it could be gender based, it could be geography based, it could be socio-economic indicators, it could be many other things. But we would observe that there is a large scale inequity when it comes to accessing eye health services. The second is a changing population demography. India is a young country, in comparison to, let's say, Japan or China, where most of the people are aging. But once India crosses that advantage, or the, when we call it population dividend, we would also be an aging society, and probably the demand for eye care would be much more than what we have today. So in future, we can expect much more demand on eye care than we have today. Inadequate government priorities. Speaking from my experience, when we go to the districts and see what the district collectors and the administrators are looking for, and when they review their programs, probably if it is a 1 hour program, then last 2 to 3 minutes they would only touch upon the eye care progress, and just to only just number of spectacles or number of surgeries, something like that. So if you look at the priority of the government, that is also is very much inadequate. So if the administration doesn't want to prioritize, then probably all the program resources, program implementation, everything takes a backseat. The next challenge is fragmented health services and a very poor integration into the systems and coordinated with other health areas. Eye health is definitely is looked up to in silos. You would find a very less synergy between other health programs. And even though they're trying to do it with NCT clinics and other things, but if you go to an NCT clinic in India, you will find eye care as a less priority for them. Workforce, definitely the big challenges, uncoordinated, unorganized. There are different curriculums available, different skill sets available, and the level of competencies varies from different geographies, different cities, urban, rural. Lot of uh, you know challenges in that this uncoordinated work. Lack of resource definitely is. Financial protection is a major issue. The flagship health insurance program, PMJAY, in India, in some of these states it covers cataract, in some of these states it doesn't. DBCS provides, but many people know what are the challenges in that. And more than all these challenges, there is gaps in data. Overlapping of data, duplication, non-reporting, many such issues in the data. So when we have all these challenges, and we have to design a program, all the program managers face this kind of dilemma also. Madam Elizabeth was speaking yesterday regarding the dilemma that a program manager faces when you design a program. I have a different set of dilemma when we design a very comprehensive and holistic program. Some of the things that we always considered eye health is to be a public health program. Earlier, it was a mere eye health program, not much integrated into the public health, but even we considered it's a public health issue. The now narratives which links eye health to a larger developmental agenda shall we set our goal at achieving a SDG goal or vision-related quality of life, which contributes towards economic development, social indicators, or other things, or shall we remain within a public health domain? That is a big dilemma. Focus. Increased CSR versus reduction in prevalence of blindness. If you refer to the latest RAB study, which was published in 2020, it says that the prevalence of blindness at 0.3% level nationally. But if you go to the districts, majority of the districts you would find that they have a prevalence of blindness much more than that. Recently, Sightsavers India conducted RAB studies in some of the states, and we fear publishing these RAB results because it has a very stark contrast to what the latest RAB study published by AIMS and Government of India says. So we are often encountered with this challenge whether we should put our focus on increasing CSR or should we make it more towards reduction and prevalence of blindness. And another question related to this, whether increased CSR would eventually reduce prevalence of blindness or not. That's the question that we need to answer. The next one is increased volume of surgery versus improving quality of outcome. Again, referring to the RAB study, it says 7.2% of the blindness is attributed towards surgical complications. And ironically, whatever data we get from even large volume, uh, charitable institutions, we struggle to get the post-operative visual acuity data. From the government sector, definitely we don't get any. And even from the charitable hospital, they would have a data of, let's say, around 60% or 70%. So qualifying at the visual acuity is very high is a challenge. I spoke about equity in my last slide. We often come with this challenge of whether we should design our program on an equality-based principle or equity-based principle. And when I say equity, I was just referring to a report on global report on health equity for persons with disability. It says that around 16% of the globe's population have some kind of a significant disability. And if we look at our data, are we concerned enough to design a program specifically for persons with disabilities, considering that they capture around 16% share of our population? May or may not. We need to understand whether we should shift our focus. Need-based or convenience-based. Even I look at Sightsavers India's program a few years back, we used to do program where there is a presence of a good hospital. But we changed that in our current strategy and we said, we will first define a geography, irrespective of whether there is a good program partner, whether the district hospital is working there or not. But we would move out from a need-based programming to a convenience-based program, and we will do program in such areas where people needs is the most, not whether there is a presence of a district hospital. Similarly, geographic inequities, similar to the identification of a particular district, single stakeholder approach or multi-stakeholder approach. Conventionally, if you look at our iHealth programming, it's based on, capacitating ASA workers, frontline health cadres. This has probably not yielded much result. We have been training ASAs and frontline health workers, Anganwadi workers for a long time. But probably they are overwhelmed such an enormous amount of work that they also prioritize very less towards the iHealth activities. So can we go and think beyond the traditional stakeholders and move out of that and adopt a multi-stakeholder collaboration? In Sightsavers, we have now collaborated with mostly with self-help groups, the joint forest management committees, the Bunker societies, the weaver societies, and many other stakeholders who might not have any direct linkage with the health sector. Another dilemma that we face, or some of the concerns that we face, whether we should focus our priorities at improving the output of the partner, or we take district as a unit and enhance the output of the entire district. There are challenges associated with it, but can we also see that the district as a whole is improving? And when I say district, I am considering both a private player and charity hospital as well as a public. Another one is a standalone iHealth program versus a convergence with our program. Consciously, in all our Sightsavers programs, we try to converge iHealth programs where there is the presence of other related programs, maybe a inclusion program or maybe a rehabilitation program, maybe an education program or a school health program, so that more program convergence and synergy can come. So while designing a holistic program, these are some of the concerns that probably we have to keep a watch on, so that we can take into consideration while designing this kind of thing. Based on this, we have come up with some principles on which our entire Sightsavers programming is considered or designed. And we said our primary goal would be towards reduction of blindness and not on improving the CSR. Because we realized of late that improving CSR may not always contribute towards the private experience. And we said that whichever district we will choose, we would at least bring it to the level of national average, which is, as of 2020, it was 0.3%. They have recently announced another set of draft studies. Probably it will be commenced very soon. Probably they will declare it at 0.2% as the prevalence at a national level. But what we intend that we would at least bring it to the 0.3% level. Thereby, we are saying where to stop. We have to set a deadline that okay, this much we could achieve and a given a time. Second, we said that all of this cannot be done with only one single partner. We have to collaborate very strongly with the public. So whenever we do a program, we take district as an unit. We collaborate with the public health units also, starting from CHC, PHC, and the district hospital, as well as a charity partner. I was speaking about this report about health equity of persons with disabilities. In all our programs, we take a principle that we would proactively seek and create opportunities for persons with disabilities to come and access our services. That's where our inclusive eye health program comes into play. And along with this, in any district that we do eye health program, we try to integrate with our social inclusion program, which is more towards economic rehabilitation, livelihood, and overall inclusion and rights for persons with disabilities. So with the inclusion of this social inclusion programs in a rural eye health program, that makes more synergistic and convergence effect. I also spoke about this proactive multiple partners. And when I say this, I eventually mean that irrespective of whether there are health sector cadres, we should go beyond and partner with the non-traditional sectors like the forest, the tribal development ministry, the textile ministry, and many other. For them, probably health may not be prime concern, but their people also needs, their client group also needs a better eye health, a better visual health. We said we would have an innovative HR model. In that case, we're saying that instead of having a very intensive HR intensive program, can we converge with another program which is also deploying some of the HR in the program areas? Take for example, a malaria program or a filariasis program or a HIV/AIDS program. Do they have any staff who are working in the field? Can we converge with them? Can we create synergy with them and not use resources for that? Another program or another principle that we feel that we cannot ignore the role of technology in whatever we want. That can reduce the effort, that can enhance the program quality, that can bring in many other resources together. So technology as a key driver is a principle that we adopt in all the programs, be it a technology, either technology in monitoring framework, be it a teleophthalmology, be it a new technology in equipment, whatever, but technology is considered to be a key driver, key principle in all our programs. And along with that, we also understand that human resources, their skills, availability is a major issue. And we said that wherever we do this kind of a holistic program, we try to place a Sightsavers India fellow who are trained by us for 2 years and they're posted in such districts which address the large need of trained and skilled ophthalmologists. So that is also integrated into this. So when we conceive this program, we try to address all the challenges that we face so that we assume that all these things, when are put in place, they will converge, it will be a synergistic effort, and together we can reduce the prevalence of blindness. So these are some of the program principles. When you look at a district, a typical district, this is what it looks like. So Sightsavers India, whenever we go to any program state, the first step that we do is that we sign an MOU with the NHM or the Director of Health Services, so that even though we work at a very community level, there is always a enabling environment that is created at the state level, and all the district and the community cadres always get the push from the top bosses, from the NHM, Principal Secretary Health, so that eye care is prioritized in the entire state. And we also understand that each and every district is unique, and we cannot have one size fit for all. And then we need to create strategies for each and every district. That is the reason that we do a very thorough analysis of the district, create a vision plan, and then strategically move into that district. My next slide will probably tell you some of the steps that we take. We call it as a roadmap, and we follow a 6-step methods while designing this program. The first step starts with the analysis. Second, we set a goal for that district. We leverage what are existing resources there, and then we strengthen system. And when I say system, it's both public, private, charitable, all systems included. And then we build local capacities. And no, not the least, that is the measuring impact. So in this 6 steps, that is followed for every district. And within the analysis phase, we try to understand the barriers and strengths. And we use a tool that's called District Eye Health Assessment Tool that is being used for all the districts. And we try to understand who are the stakeholders there. We conducted stakeholder analysis. We try to understand what are the equipment, what are the HR, what are the challenges, what are the economic and social barrier. Is it a tribal district? Is a district infested with a forest area? Who would be our major stakeholder there? So these are some of the analysis that we do and design the program based on the local context. Second, when we set goal, the goal is set for the entire district, and a district vision plan is created. In generally, this district vision plans are presented to the district collector so that it gets a approval or an some kind of endorsement from the district administration, and it is not considered to be a Sightsavers vision plan as such, but it's more of a vision plan for the district. And then we break it down, go to block and the panchayat, and thereby we can use the panchayat registration. Second, when it comes to the leverage, we try to engage more of the non-traditional sector along with the traditional sectors like ASA and Anganwadi, along with that the other non-traditional sectors. And system strengthening is definitely one of our core principles in the program. And whenever we design a program, we design for both the parts, building the capacities of the CHCs, PHC, district health unit, along with the charitable and private. And all these things, our emphasis is on creating an enabling environment through building local capacities. And the last but not the least, how do we measure that we are progressing or not progressing? We start with most of the cases, we start with a RAP study, end with a RAP study, and prove that the prevalence has really come down. So this is, in a nutshell, our design for the holistic program. I'll end my I probably have lost the time. And these are some of the areas where we are working around 10 states, 130 districts. And out of this 130, we are considering 25 high impact districts where all this programming are there. And you can visit some of the districts and see how this program approach being operationalized in all these 25 districts. And slowly phase wise, we will move to other districts as well. And I will end my slide here saying this sentence that vision health is not a luxury. We cannot take it as a luxury, but it's a fundamental part of our programming to ensure safe and prosperous future for us. This was from my side. Thank you so much.
Thank you, sir.